What I'm going to talk about is very dry compared to what Vivian just presented, which is a really compelling argument for protecting our children against some of the very sophisticated and possibly immoral digital advertising techniques. What I would like to do, what I would like to do is to talk about the lifetime cost of childhood obesity in Ireland, in Northern Ireland. We know there's a couple of background facts. The McKinsey Global Institute report recently put obesity as one of the top 3 contributors to global burden of disease, costing approximately $2 trillion American dollars per year, up there with smoking, armed conflict and violence and terrorism, and alcohol. In a study in 2012, it was estimated that in Northern Ireland, about 450 million pounds per year was the cost of treating adult obesity in Northern Ireland. As has already been sort of said, children who are obese, particularly in adolescence, are at a lot higher risk of tracking into being obese and overweight children. Although childhood obesity has been rising, although it appears to be stabilising in some high-income countries, in some population groups, but even where it is stabilising, it's at an unacceptably high level. So, for example, on the island of Ireland, 1 in 4 of our adolescents are either overweight or obese. One of the things that, in the light of this evidence, in 2016 to 2017, an EU joint action on nutrition and physical activity called JAMPA was initiated. Its aim was to try to halt the increase in obesity and overweight in children and adolescents by 2020 within the policy and action context that the EU had been working on for years. This was sponsored by the High-Level Group on Nutrition and Physical Activity and managed by DG Santé and Shafia. There were 7 work packages covering a range of issues, and you can find out the outputs of that project on going to their website, which is jampa.eu. We were asked by the Department of Health in the South to lead a work package 4 on strengthening the economic rationale for tackling childhood obesity. Because the lifetime impacts, or the impacts and the costs, most of them occur very much later in life, arising out of childhood obesity. And so rather than looking at the cost of treating or managing obesity in any particular year, for a condition like childhood obesity, you really have to take a lifetime perspective and look at not just the current costs, but the future costs. And so Work Package 4 aimed to comprehensively estimate the lifetime human impacts and financial costs of childhood obesity and overweight, and also to estimate the effect of 1 and 5% reductions in mean childhood BMI. This is the first time the method was tried in more than one country. We tried with 8 of the countries, 8 different countries around Europe, and the Irish arms were co-funded by JAMPA, but also by Safe Food, and they funded an extension of the project to Northern Ireland. There were some issues that we faced with modelling. This is a desktop modelling exercise, and the final results for Northern Ireland and Republic of Ireland are presented here. What I would do, so our aim was to try to estimate the lifetime cost of childhood obesity, and we're able to. This was done by way of a very large micro-simulation model, and these require large amounts of data and large amounts of research. So you're only able to incorporate the human impacts and the costs for which you have quite comprehensive data available. And I'll just go through now. So what we were able to include were these consequences of childhood obesity, both in childhood and in adulthood. Child obesity affects people. Obese children are more likely to become obese adults, as a result develop obesity-related diseases throughout their life course, and also die prematurely from it. They also affect the economy. As people develop child obesity-related diseases or die prematurely, there is productivity losses due to premature death, and lifetime income penalties which are associated with just being obese and overweight. The literature suggests that somewhere between 5 and 10% people who are obese and overweight as adolescents, their annual average income, lifetime income is reduced by 5 to 10%, simply as a result of being overweight and obese. They also affect social services. There are productivity losses due to absenteeism, and also these adult obesity-related diseases need to be treated and managed. And in our model, we were able to include the GP costs, drug costs, and also hospital care. So these were the consequences that we included in the model. It's not all of the consequences. In particular, we weren't able to include the indirect costs to patients and their families and their communities. We weren't able to include the psychosocial costs to children and how that fed through their attendance at school and their performance at school and readiness and the performance in the workplace from an economic sort of point of view. There's relatively strong evidence that these effects are good, but we couldn't include it in this sort of model because the data was just too demanding. So these are the sorts of data inputs. These microsimulation models pull together data from a whole stack of different purposes. And these studies really are best done by long-term cohort studies with very long-term follow-up, but there aren't sufficient of these addressing obesity and its drivers to undertake this sort of analysis. So it's done using these simulation models. So we need a range of data on the population, on the mean BMI and historical BMI distribution in childhood as well as in adulthood. We need the risk of disease that's associated. Here we need the per case costs for primary care, hospital inpatient, outpatient care, and drugs. In terms of the lifetime income penalty, we need to work out what we're putting down that on. Average annual income is required. Days absent from as a result of various diseases, and a whole stack of other subsidiary information to calculate some of the metrics that are going. Theoretically, all of this data is required. All of this data is required for all ages and not just children. Needs to be broken down by gender, by age, by BMI status, and by disease. There were 29 potential diseases, adult and childhood diseases, that were potentially associated with childhood obesity or adult obesity, which we included in the model. So these are very demanding, and you can see that unless consequences are not included in this model, they need, one, to be real, and two, a huge amount of data about these detailed breakdown data is required before we can include it in this model. So just because a consequence is not included in this model does not mean it's not important. It simply means that the data is not being monitored and is not available in the detail that's required. That's a major drawback from this sort of study. Okay, there are the data requirements. Because we're trying to do this over 8 countries, we developed we need a conceptual framework. This is a conceptual framework that was used by Fernandez when he was estimating et al. In 2012 the direct costs of childhood, direct healthcare costs. And the arrows here, the evidence is quite strong and reflects the various pathways by which the consequences of childhood obesity are experienced during the life course. Yes, there is some evidence. The UCC in the South did a literature review of the adult consequences of childhood obesity and found that the evidence of direct links between childhood obesity and adult diseases was mixed. and that most of the consequences were mediated through the fact that young children who are obese tended to be to grow up and track through to being obese as adults. So we included those, and then these are the, as I was saying, Fernandez dealt with the direct healthcare costs. What we did in this study here was to look at societal sort of costs, the economic costs that are associated, and not just the direct healthcare costs associated with childhood obesity. So this is how the model works. What we actually do is we take a representative a group of 20 million virtual individuals, children aged 0 to 18, who are representative of the children in Northern Ireland in our base year was 2015. We then used the historical data from Northern Ireland, the BMI data, and we modelled their lifetime BMI trajectories and 1 year at a time. And then using the research we know about their obesity status and their risk of disease and the diseases that they may or may not develop, we record those over time. Sometimes they die prematurely because of those diseases, but also they receive healthcare costs and incur absences from work because of premature death or absenteeism. And so we run this model, 20 million iterations, and we collect all this information. We construct the histories of these 20 million virtual individuals, and then we summarise those into a number of model outputs. And those outputs relate to their obesity, prevalence in adulthood, the occurrence of disease, and also treatment, and also whether they die prematurely. And then the financial costs are included there along the way. Okay. Now, to estimate the excess costs associated with childhood obesity, what we do is we run this, we look at those children, individuals who were obese as adolescents, and we record their costs and impacts. And then we look at the costs and impacts for children, for people who were of healthy weight as children. And then by subtraction, for each of those outputs, we can get an estimate of the impact or cost that's attributable to the fact that they were obese or overweight as an adolescent. And what I'll just do now is just run through. We estimated in Northern Ireland, for example, if we took the children who were alive in Northern Ireland in 2015, we estimated that about 30,000 premature deaths that they were going to experience were directly attributable to the obesity and overweight that were prevalent in that childhood population. So it had a significant sort of impact on premature death rates. But what I'll do now is just focus on costs. This slide here tells you that the overall lifetime cost of childhood obesity in Northern Ireland is about £2.25 billion in current 2015 values. These costs are all discounted. And discounting is a technique that economists use to discount future costs down to current values. We all have a time preference. We all like to have the good things that are going to happen to us happen as soon as possible, and we like the bad things that are going to happen delayed as long as possible. And it's more than to do with preference, or we just have a time preference. And so economists discount future value, future costs. And of course, in a lifetime study, they need to be discounted. And in this study here, the costs were discounted at 3.5% per annum. And to understand what £2.25 billion in current values mean, what you'd have to do, if you decided that you recognise that the obesity and overweight that were in the current childhood population is going to result in costs in the future, and you decided you're going to cost it and put that money aside in a bank, and so that you can pay off those excess costs. What you'd find is that what you'd need to do is you'd need to take in 2015, £2.25 billion sterling. You'd need to put it into a bank account, which earned 3.5% per annum compound, leave that money in that bank account, and only take out money to pay those costs as they occur over the future. If you did that, by the time the last child died, there would be no principal and there would be no interest in that account. So this is a significant burden, a legacy of financial costs that we're leaving to the future, which is going to require about £2.25 billion put aside today if we wanted to save our children from incurring those excess costs. What it means is that for each family which has an obese child in the family, they would need to put aside about £20,000 into such a bank account. I'm not sure of any legal bank account that earns this sort of interest rate. So it's a very tall order, and that's the total financial cost of it. Okay, this next slide gives you a breakdown of how those financial costs are distributed. And what you can see is that I've divided these costs into two sections. The first section, what we find in Northern Ireland, then the figures on the top pie chart, figures for the Republic are in the south in euros, but approximately a quarter of these excess costs are direct healthcare costs. What you have is that nearly 2/3 of the cost is actually not cost to the direct healthcare system, but cost to the economy through lost productivity, particularly due to premature mortality, but also from absenteeism, as people are living through the absences from work experienced because of obesity-related diseases. So one of the main messages here is that yes, it is a very substantial burden on the healthcare system, but it's also a very much significant burden on the economy, and more this has become an economic issue rather than solely a health issue. There are some interesting gender differences. I'll just speed through these things in Northern Ireland, which were repeated in the Republic of Ireland, is that the lifetime financial costs are higher for males than they are for females, and there are the figures there, particularly higher in Northern Ireland. Males tended to incur higher lifetime income penalty and excess productivity losses due to premature mortality, while on the other way around, females tended to experience excess direct healthcare costs and excess productivity losses due to absenteeism. And in a way, these are a little bit counterintuitive, but essentially they are explained in part by the fact that males tend to present with more severe diseases, they have higher premature mortality rates, and their incomes are generally, on average, higher. While on the other hand, females are more likely to seek and to utilise healthcare, and that explains some of these differences. There were some differences between the north and the south. I'm just presenting in high-level figures here. The lifetime costs were actually higher in Northern Ireland per person, and direct healthcare costs were relatively higher in Northern Ireland, and productivity losses due to absenteeism were relatively higher in the south. And this is in part explained by the fact that we used a higher discount rate in the south, so that future costs are discounted more heavily, and that makes a difference when you collapse things down to current costs. But also it's due to the fact of the different healthcare systems. We have a two-tiered private-public system which dominates in the south, as distinct from the NHS, which runs in the north. But once again, it also emphasises the importance of taking into account the socio-demographic and the health services, health and social services context in the north. One of the other things we wanted to do was using the modelling exercise to estimate, well, what sorts of savings could you experience, and I've just here got the financial cost savings, if you could reduce the average BMI of children in Northern Ireland by 1% and 5%. And the way that we did this is that we ran the model with the current BMI distribution in childhood, and then we calculated the costs. And then what we did is that we changed the BMI distribution in the initial cohort to 1% or 5% less than it was, and then ran the model again, calculate the excess costs, and by taking them away, we can get an estimate of how much cost savings we can expect if we reduce the BMI by 5%. So this is the savings. What we estimate is that, again, in 2015 values, we estimate that there's a savings to be made of £350 million in 2015 costs, and approximately about 15% savings across all of the cost categories that were there. So these are very substantial savings. Remember that we'd have to put away £350,000 in such a bank account to cover these. That's how much less we'd have to put into the bank account if we could reduce the mean BMI by 5% in children. Okay, so I think what Mimi presented was a very strong ethical case on protecting our children. And what is emerging from these studies, and it's becoming more and more interesting at the European level, to the economics and finance departments and DGs, is the economic costs of childhood obesity. If you look at most of the economic think tanks that are producing reports on these sorts of things, they're recognising the economic costs are very substantial. And so there's a very strong economic imperative to tackling childhood obesity. But just quickly now, just to end, we were not able to release the figures, complete the modelling for the other countries. They've been put on hold because of some modelling and data problems. But the OECD recently agreed to incorporate this sort of modelling into their economics of public health modelling program that they have, and was accepted by the Health Committee on the 27th of June in Paris. And we're currently negotiating the final details of this thing. So we expect this work to continue, and some updates of these things to come out, in particular for Northern Ireland and the Republic of Ireland. Okay, these are just some of the benefits of this sort of approach, and I'll just stop now and ask if anybody if you have